solve. But now let's go ahead and introduce Dr. Regan. Dr. Regan is at Premier Kettering Health Network, Ohio. I'm going to tell you that I met Dr. Regan a week ago, and I was so impressed. You're going to see some wonderful cases. And he also, what caught my attention, just like Dr. Mullane, he's interested in the cellular molecular level of wound care. And I love to change the paradigm. I like to change wounds by attacking the wound itself. And of course, that's after we deal with the whole patient. So Dr. Regan, take it away.
Thank you. It's really an honor to be here with everybody. And these are great cases, very challenging cases. And we obviously all chew some of the same dirt. So helping each other along is most of what we like to do. I'm going to show you a couple of illustrative cases that of things that we normally see day to day, not the exotic stuff, but the diabetics that are high risk, peripheral vascular disease, peripheral arterial disease, mixed disease, connective tissue diseases, anesthesia risks such as cardiac issues, and perhaps a little mix of some renal issues as well, where you're really having to calculate how far can I take this patient without doing more harm than good. And we don't usually worry about people dying from the effects of foot or ankle or leg surgery. We worry about anesthesia. So having the tools and the mechanisms to employ that are effective but reduce the risk and maybe even the length of stay of the patient are incredibly important. And I've always been wanting to move towards synergy in our stewardship of these patients. How do we get the patient out of inflammatory state? How do we get them out of the infected state, convert them to clean, and then make them a potential candidate for limb salvage and repair? And it's an additive type of process, as all of you know. You start with simple protocols that you learn when you're a resident, and you build ever more complex problem-solving scenarios to address the challenges that rise to you. This is an interesting and very frequent type of scenario that I see. I've done dozens of these cases with exactly this protocol. And we have a open fracture of a second toe proximal interphalangeal joint with joint sepsis osteomyelitis. You can see the slide on the left. The toe is dislocated dorsally and it is fractured and infected through the joint. He's had IV antibiotics, he's been elevated, and we've been using Domeboro hypertonic acetic wet dressings to encourage and consolidate drainage, reduce contagion. It's, of course, acetic, so gram negatives get knocked out. It also exfoliates passively and gently exfoliates devitalized tissue. So with that prepped, he looked a lot worse when he came in, but clearly he needed an amp of the toe. Nothing else is really going to work for this guy. And he had very limited options for anesthesia risk and everything else, including his PVD status. So an open amputation was done with a slight curvature, plantar medial. If it was the fourth or third, it would be curved plantar lateral. On the other side, it'd be curved plantar medial and a slight lazy S dorsally. This allows you to open that up, transect the metatarsal, and dissect everything forward, excising the synovium and the flexor plate. So all you have is muscle in that compartment, muscle and skin. And you take the long flexor and you cannulate the flexor canal, open that up and put a drain out through the plantar aspect of the foot, so you don't have any trapped drainage. So after irrigating that with solution and seeing everything viable, hemostasis, that's when we employ the Phoenix graft by parachuting it in, and in a diamond shape, basically pack it into the wound, anchor it with usually north, south, east, and west of some 2-0 or 4-0 monocryl, to anchor it in place, and then pack the wound open, keeping that good contact with the wound interface with gel foam. So that's a passive packing. I don't like hard packings. You don't pack and wrap is what I always taught my residents. But you can use a passive soft wrapping like gel foam because it turns into a jelly. It's hypertonic, and basically you leave that in the wound, and we usually don't take these wounds down for at least 2 or 3 days. We pull the drain, we take a look, we culture the drain if we have any concerns. But at that point, we can decide then, is this patient a good candidate to go back to surgery to do a secondary repair? Or would this patient be better off being followed as an outpatient? And either becoming a better candidate for secondary repair, or can we treat this patient and heal him by secondary intention? And the secondary intention option is the best for most of these patients that are elderly, bad circulation, bad anesthesia risk, et cetera. And you can see that within 4 weeks, we usually take the graft out by the 4th week. 3 weeks, 4 weeks, we'll take some of that gel foam out, and it'll squeeze out passively by itself too. We release the sutures and peel out that residual Phoenix graft, and now we've pre-laminated our wound, and it looks beautiful. It would be a pleasure to take and do a secondary repair. It's been converted clean, and the wound surfaces are now pre-laminated for repair, but you don't have to repair it. All you have to do is stand back and let the body be the hero. And you can see that 2 weeks later, you can see it's going to be closed. The deep part is closed. There's no depth. The muscle is revascularizing the wound. And 8 weeks afterwards, this wound is healed and the patient's ambulatory. He did not have to go back to surgery. He did not have to risk all kinds of other things. And these patients are so risky, you can't even wrap them. You know, I mean, you put Kerlix on this kind of a patient, you're going to wind up with 4 ulcerations. So the dressings are simple, everything's simple. The nurses love it. And this is a good intervention for a patient that you either need to do a long transition from acute IND conversion to clean wound and repair, or you need to consider that they may have to have secondary repair. So I think this is a useful application, especially for this modality, and it's been very helpful for my patients. Get the next series, Joy. Yeah. So, and this is one that we see all too often. A new onset diabetic who's not aware that his foot is infected and goes on, blows out a joint with joint sepsis, osteomyelitis, and a big soft tissue loss, full thickness soft tissue loss. So what you're seeing in the pre-op is sinus tract into the joint and rotten tomato syndrome. And his first post-op week, you can see that it's still kind of irritated. So we go back, we keep the, and this dry gel foam is what you see there, the white stuff. The gel foam and the Phoenix graft are indwelling. And we'll start with some more of the hypertonic acetic wet dressing to convert that to a cleaner wound. But we leave the internal components, the Phoenix graft, intact. And you can start to see by the 4th week, he's shedded off most of the gel foam has been squeezed out of the wound. And there's no inflammatory effect in the wound borders anymore. All the gel foam is gone. And this is 8 weeks post-op, and he's just about healed. So this, I can't argue with this, you know. We did a flap closure of the plantar aspect of the wound after a week of the hypertonics, but left the dorsal part of it open. And this is his post-op after repair. So this is a fairly large deficit that we still had. Now, my option was to take and do a fillet flap, pedicle flap using the fourth toe, but I didn't want to do it because I really had confidence that we could close it with the Phoenix graft. And we had muscle transposed. The intrinsic muscle transposition was done here to give us good vascular basis and bed for the healing. And you can just see how that contracted in 3 weeks and then it's closed down. Very happy with that. So I think my main concern, I typically use this after an incision and drainage. And when I'm concerned, especially that I need to establish whether I have a viable wound bed that's a good candidate or a poor candidate to return to surgery, the Phoenix makes the difference. You know, it sounds crazy, but even within 3 days of putting a gentamicin impregnated Phoenix graft in an open wound that we have done excision of bone and soft tissue with, it looks like a different wound. And then you have the option. We need to wait till this patient's revascularized. That happens all the time. I'll do an IND like this. The patient will need to go to the cath lab. They might need to spend a couple days getting him set for that. Might have to de-escalate his antiplatelet therapy before we take him back and do a repair. So in this case, you might have to wait a while. Might have to wait 2 weeks before you get it back to surgery. You've done what you can, and you're really staging the patient for success by interposing that Phoenix graft. And it's been a very tried and true mechanism for something that we commonly face. You know, these decision-making protocols get a lot less complex when we have an effective tool. Anybody have any questions?
No, that's phenomenal.
We have a lot of other cases. I mean, I've done a ton of cases with it where we did more complex repairs. But the most important stage is that confidence that you can build in getting from the dirty, ischemic, inflamed wound to the wound that's prepared for repair. Okay? And we have plenty of stem cells. We don't need to put stem cells in a wound. What we need to do is create a platform for healing by converting them to a non-inflamed state, because we know what stem cells do in an inflammatory state. They have two options. They can die or they can make scar tissue. Sometimes scar is a safety valve, at least temporarily, but we don't prefer it. And what we like is phenotypic specific regeneration of tissue that can only happen with stem cells when you have resolved the inflammatory state and create an opportunity for stem cells to do their thing. If I think you'll all agree with that.
Mike, this is a fascinating case, because the other thing I see, and it's brilliant the way you're applying this in terms of this internalization component, and then being patient in terms of the observation. But as I look at pre-op to post-op to 1 week, and then 4 weeks, with the really good resolute decrease in inflammation and decrease in the accompanying interstitial edema, you're maximizing that microcirculatory reperfusion.
Yeah.
And you can see it demonstrated in these pictures. And so it's really a disproportionate change in a short period of time with what you're accomplishing. So I'm really impressed with how you're applying this. And from talking to you last week, this is a pretty routine outcome in your practice now. Is that correct?
Yeah, it is. Yeah.
And I think, again, getting back to our passion on the cellular level, endothelial cell function is clearly better as inflammation goes down and there's that change in the proliferative phases of healing. And again, that's all based on removing rarefaction. So you're recoupling microvascular perfusion down to that 5 micron level. And there's not a lot of grafts that I have seen that have the ability to do this. And it's a great, unique application of this. So congratulations to you and your team on what you're accomplishing.
And Dr. Regan, there's some questions coming in,
Sure.
and I do have a lot more for y'all. But if we go back to the other slide for the second ray amputation, Beth, the question for that one was, what guidelines are you using for a drain on this case?
Well, usually what we're concerned about is residual infection in the flexor canal. It's the most common scenario causing complications with any digital amputation. As a matter of fact, a lot of the digital amputations I see done do not address the problem at all. There's the gangrene of the toe is the symptom of the disease. The disease is actually the flexor infection choking off the venous return, and then a secondary wet gangrene occurring because of the outflow obstruction. So unless you go in and take out that metatarsal head, they're probably not going to get better. If you don't at least decompress the flexor canal, they're not going to get better. So that's incredibly important. And don't know if that answers the question. What was the question again?
It's well, we were talking about what guidelines would you use for a drain on cases like this?
Oh, for drain. Okay. So if you talk to one of my former residents, I had some of the brightest people in the world to work with. You know, you taught them a little bit and then you got out of their way. You know, they're really smart people. But if you were to say no drains, question mark, they would say no brains, because especially in closed compartments and tight structures such as we have to deal with in the foot, you have to use drains. And we prefer to use small blue vessel loops, which are solid. They're made out of silicone. They're not a two-way street. I like passive drains in particular. I will point a hemostat. I'll follow the flexor canal. You can't see the drain because we're not seeing back far enough, but I'll take it all the way, halfway down the foot to where I know there's no inflammatory signal, and past any of the retinaculum that could trap fluid, point it out to the skin, make an incision, and draw that vessel loop out. Okay, so that'll trail from the open incision here through the plantar compartments. And if I see any dorsal inflammatory changes and it looks like there's something, I won't hesitate to put one out proximal and dorsal as well. I don't like tubular drains. I don't like a two-way street that can reflux back into my wound. Okay, the decompression of these wounds is incredibly important, and especially after you do a flap. If I do a muscle transposition and a fasciocutaneous flap, I'll use 3 or 4 of these, maybe 3-inch pieces of the vessel loop drain as incision drains, and you can thread them right out through the incision and pull them in 48 hours, and it has no effect on the wound healing. You can even leave them in for a week. They're passive. They're soft enough that they don't occlude any structure. They won't put any vascular embarrassment on the tissue. They're radiopaque and they're silicone, so they're non-conductive, you know. So I really like them, and it's cheaper than the silicone incision drains, which are nice, the flat ribbon drains, which, you know, I grew up using as a resident, but they're very expensive comparatively. So the vessel loops work quite well for that. And I would always use a drain unless there's some specific reason not to.